please.
Please play the video.
Yes, thank you. You are welcome. Me too.
Interpretation and the pitfall. Let's start from challenge case 1. This is non-contrast CT and post-contrast CT. We can find there is true lumen and the false lumen. Lower enhancement of the ascending aorta noted. The sagittal reconstruction showed there is a defect over here, and the false lumen involved the ascending and the descending. So, is this a type A or type B dissection? Please poll. Challenge case number 2, acute chest pain. Initial CT showed the abnormal thickening of artery wall over ascending and descending. 5 days later, one small new lesion and one large new lesion was noted. Question is, which lesions are at risk of progress? 11 months later, the small one become a big false lumen and the large one have totally resolved. Let's start from the basics of acute aortic syndrome, which comprise at least 3 major types. Aortic dissection. There is intima defect and patent false lumen, which accounted for about 60 to 80% of AAS. Second is intramural hematoma. By classical definition, there is no intima defect and large blood clot, accounted for 10 to 40%. Penetration arterial ulcer. There is pre-existing ulcers and the plaque, and develop a penetration ulcer to cause pseudoaneurysm or focal IMH, and it's less than 10%. Let's think about why and where the aortic dissection occurs. This is histology. We can find the intima is very thin endothelium. The media is thick, has smooth muscle cell. The adventitia has ridge of vessel. The total thickness is less than 3 mm. And thoracic aorta is much thicker than abdominal aorta. The perfusion of the aortic wall outside is from vessel, and the inside is directed from the luminal diffusion. Therefore, in the middle of the medium has less perfusion. In the case of aging or hypertension, is most likely to become ischemia and cause smooth muscle cell degeneration, then fibrosis, stiffness, and increase of shear stress. Therefore, you will become dissect. The dissect actually occurred in the media. Therefore, we should call it intima media flap, not intima flap. Let's go back to the challenge case 1. Here is the intima media flap, and the lumen retrograde involve ascending and descending. By classical definition, any false lumen involve the ascending aorta before the innominal artery is called type A. the other is type B. So our case should be retrograde type A. However, in 2020, Society of Vascular Surgery and Thoracic Surgeons proposed a new classification which solely depends on the entry tear location. That means, for this case, the entry point at the ascending aorta and it extends to the segment 9, so it's A9. This case, entering at the segment 1, entering to 9, so it's B19. And importantly, this case, entrance at the segment 2, retrograde to segment 0 and 9, so it's B09. I just want to inform you that there is a new classification proposed and we should be aware about this. So about the terminology, this is type A, A9. This is type B, yes, B29. And this we usually call retrograde type A. Now you can also call it B09. Okay, then we talk about intramural hematoma. Here is challenge case number 3. This is non-contrast CT, and this is post-contrast CT. How do you think about? Is this a penetration accessory ulcer with IMH, or it is a IMH with ulcer-like projection? Please pause. Why do we want to talk about IMH? Because as compared to the Western country, they have a much less IMH in acute aortic syndrome. But ASCI people has much more, and it is about 25%, even more than 30 up to 50%. So it's more popular in Asia. And the in-hospital mortality of type A IMH, Asia people also have better than the Western people as compared to the aortic dissection. About the pathogenesis is a mystery. One proposal is it comes from rupture of vessels and no intima defect. This is the classical definition. The second one proposal is there is a tiny ulcer and developed into IMH. However, this ulcer may be spontaneously healed or too tiny and not visible on CT. Studies supported this proposal, including this one. By actual 3 to 5 mm scan, there is no any defect can found. However, with the sagittal reconstruction, clearly there is an intima defect. There is ulcer here and here. Therefore, the author conclude there is considerable portion of patient with intima defect by MDCT, even in very early stage, and it should be pay attention on follow-up. Study using intravascular ultrasound further review there is ulcer projection but cannot be seen by CT scan. And follow-up CT scan show the enlarged ulcer projection, so therefore it can be seen on the CT scan. The third proposal is that it comes from intramural hematoma and develop a new ulcer and fourth lumen. Support case is this one. Non-contrast CT scan and the post-contrast we can find thickened artery wall is type A IMH. Follow-up showed there is a new ulcer-like projection here, and eventually to avoid fourth lumen. So this is IMH, new ulcer-like projection, fourth lumen pathway. If we did not scan the patient earlier at this stage, and the patient come to here at emergency room at a presentation, we may call it artery dissection type A, right? So why it is this ulcer-like projection? It is induced by the increase of shear stress of focal intramural hematoma. So it also called re-entrant tear or tiny intima defect. Therefore, IMH can go through ulcer and go to the fourth lumen or direct go to the fourth lumen. Like this case, simple IMH and avoid fourth lumen. However, it can also reverse with complete resorption. Therefore, IMH may be a precursor for artery dissection, and the diagnosis of IMH, ulcer-like projection, or artery dissection is just a matter of timing of CT scan. Now we go to another entity. This case has an early chest ray, and just 4 months later, huge opacity around the arch. CT scan review, there is an accessory change with 2 pseudoaneurysm formation. This lesion, we call it penetrating atherosclerotic ulcer with pseudoaneurysm and the focal intramural hematoma. This lesion is a disease of intima. In contrast to the artery dissection or IMH, they are disease of media. This is disease of intima. It has intima ulcer first, then go deep, cause media hematoma, to the adventia, cause fourth aneurysm, or even rupture. So now, we met a challenge. This case has IMH and the ulcer-like projection. This case has a PAU with pseudoaneurysm. Why do we call them in 2 different types? Because IMH first, and always no plaque, smooth interface, and usually single. Then this is a IMH developed ulcer-like projection. In contrary, PAU has a pre-existing ulcer and always have a accessory change and a calcification. And the interface is irregular, and you usually have a multiple along the descending. So we must differentiate this is 2 entities. Now we have another interesting case. Here we find IMH has a focal contrast here. Is it a new ulcer-like projection, or it is a PAU? let's follow up. Wow, it become bigger. So it may be a false lumen. Don't worry. The follow-up showed it appeared to decrease and the lung condition also improved. And finally, it totally resolved. So this lesion apparently is different from the ASCI projection or PAU. And I called it intramural blood pools. This case report by Dr. William, they find a similar finding, a focal contrast and become bigger. So they do an angiography and confirm there's a contrast pooling and connect to the intercostal artery. They do an embolization. The illustration is very good. So this is normal intercostal artery. When IMH occurred, the wall has suddenly become thickened, therefore tear of the orifice and cause a blood pool here. They call it pseudoaneurysm, but I think intramural blood pool is better. I will explain it later. Therefore, we have two types of focal contrast enhancement to be differential diagnosis. First one is early recognized ulcer-like projection. It has a widened opening and close to the inner side. One is intramural blood pool. It has a very tiny connection just like an intercostal artery, and the contrast is more outside and may connect with the intercostal artery or branch artery, and we call it intramural blood pool. I did a follow-up study of 65 cases and find that ulcer-like projection is related to increase of mortality and operation 7 times. But presence of intramural blood pool will cause difficult to complete resorption. It will not cause risk of mortality or surgical indication. Therefore, this lesion is relatively benign, and pseudoaneurysm implies a malignant causes. Blood pool is benign and a passive consequence as the tear of the branch artery during the development of intramural hematoma. Now I would like to show you an interesting case. What do you think about this? Along the descending aorta, one IMH, one IMH, one IMH, and the intercostal artery branch 1, 2, 3, 4. Is it like this one or this one? My resident told me it looks like this. Wow, perfect match. And we call it Chinese ring sword sign. It is intramural hematoma with progressive intercostal artery tearing. Okay, now we have 3 types of intima defect and focal contrast enhancement. One is intima defect. It's called ulcer-like projection. One is penetrating atherosclerotic ulcers. It's irregular and pseudoaneurysm. One is branch artery, intramural blood pool. It is outside and a tiny communication. The prognosis is poor over these two and benign in this one. The last challenge case is how do you call this one and how do you call this one? I will call this is diffuse aceroma, and this is PAU with focal IMH because there is irregular surface and protrudings and high density before contrast enhancement. But this is very common, just diffuse aceroma. Don't overcode this as PAU. So the take-home message is, first, in 2020, there's new classification of RT dissection by surgeons. RT-IMH is more common in Asia. Intense medical treatment is an option for type A IMH. Mystery triangle of IMH, ulcer, and the fourth lumen in pathogenesis remains debating. Focal contrast enhancement in IMH, including ulcer protrusion, PAU, and the IBP, should be differential diagnosis and management. We need a precise and uniform terminology, which is essential for correct diagnosis and management, with restrictions and a randomized clinical trial. It should be noted there has no RCT yet for AAS because it's too difficult to do that. Thank you for your attention.
Okay. Now we are going to the second topic by Professor Bongyang Hong Ding. Professor Ding, current. Okay. His topic is new trends in surgical decision making and techniques. Professor Ding, please.
Hi everyone, can you hear me?
Yes.
Yeah. So good morning, Mr. Chairman and dear colleagues. Many thanks to the organizing committee for the invitation to speak at your excellent congress. My name is Nguyen Hoang Dinh. I'm actually a cardiovascular surgeon from University Medical Center in Ho Chi Minh City. I was asked to talk about new trends in surgical decision making and techniques. And this is a very broad topic, so I'd like to focus on the decision-making and techniques involving acute type A aortic dissection, especially with malperfusion. It is a very fatal and complex disease. So let's begin with a case we got this month. A 56 years old male admitted to our center of cardiovascular surgery with sudden onset of excruciating chest pain 26 hours prior. On admission, his hemodynamic was stable and he was conscious, and his left leg lost sensation and the mobility reduced. A CT scan showed typical aspects of acute aortic dissection, Stanford type A or the Baker type 1. The primary tear was seen at the ascending aorta, and the true lumen was severely pressurized, and no dissection into the aortic vessels was seen. We can see that the celiac, SMA, and right renal came from the small true lumen. The left renal came from the false lumen, and the dissection extended to both iliacs, and there was no flow to both iliacs. Echography showed preserved LV function and a competent aortic valve. For this patient, prompt surgery is indicated to prevent acute mortality due to cardiac tamponade, aortic valve insufficiency, or myocardial infarction due to coronary involvement. As you can see here, this is what we found in the operating theater, taking into account that there was a malperfusion syndrome of the limbs. We thought we should go for extended repair of the arch to reopen the true lumen to try to reperfuse the iliacs. So as you know, the surgical strategy of acute type A dissection is actually tear-oriented. The axillary artery is cannulated, the aorta clamps, and heart arrested, and proximal anastomosis reconstructed. And when core temperature reach about 25 degrees of Celsius, body circulation arrested. And we do a bilateral anterocoax selective cerebral perfusion, and then distal anastomosis is reconstructed. The classical principles of surgery for the Baiki type 1 dissection consist of three things. First is the resection of the primary entry tear. Second is reapproximation of the dissected aortic wall layers. And three, the resuspension of the aortic valve. In cases of extensively dissected aortic root, the presence of a pre-existing dilatation more than 45 millimeters or known connective disc tissue disorder or unrepairable aortic valvulopathy, it is advised to also replace the aortic root. So we can see that it's such an simplified approach to address a complex problem. But such a simplified approach, most of the case resulting in heavy arch resection for about, in the literature, about 80% of the cases of acute type A dissection. However, the downstream aorta usually remains residually dissected, risking late and distal aortic sequelae, and therefore leaving the patients at risk for future complex redo surgery. That's why we need a more extended distal repair. But whether repair at the index procedure means the frozen elephant trunk improves long-term outcome and outweighs the associated surgical complexity and risk at the index procedure is currently being debated on. This is a recent analysis of one institutional data using a protocolized approach with bilateral anterocoax selective cerebral perfusion at 25 degrees of Celsius core temperature. So in more than 250 the Baiki type 1 patients in a 10-year period, they show 12% of 30 days mortality, 9% of stroke, 0.8% of permanent spinal cord injury. So the data in line with previously reported operative results in the IRED registry. At the mean follow-up of almost 70 months, they observe an acceptable survival rate of 86% at 5 years and 74% at 10 years. So we focus on the late occurrence of a post-dissection dilatation distally, would be defined as a diameter more than 50 millimeters. So they observe a freedom of late dilatation of 81% at 5 years and 71% at 10 years. So roughly 1 in every 5 surviving patients dilated up to 50 millimeters or more in the downstream aorta. Focusing on the need for redo surgery due to distal aortic sequelae, they observe a 30% overall reparation rate, mainly post-dissection aneurysm, as you can understand. So the 2014 ASCI guidelines on diagnosis and treatment of aortic diseases recommends that in patients with acute type A dissection and organ malperfusion, a hybrid approach should be considered. This is recommendation class 2A and level of evidence B. Also, the 2016 Canadian Joint Position Statement on open and endovascular thoracic aortic surgery recommends an extended arch technique for acute type A dissection under the following circumstances. First, primary intimal tear in the arch or beyond. Second is significant aneurysmal disease of the arch. Third is distal malperfusion. And fourth is concomitant descending aortic aneurysm. They also said that for young patients and patients with connective tissue disease should be considered an extended technique for arch repair. Therefore, the optimal technique for stent graft deployment needs to be determined. During this hybrid arch procedure, after surgical arch replacement with the Dacron graft, the stent graft can be inserted in one of two ways, as you can see in the picture. So in the picture A, the stent graft is deployed through the open arch during circulatory arrest. We can call it a frozen elephant trunk. Or picture B, image B is stage after separation of cardiopulmonary bypass or weeks later during the post-op period using fluoroscopy and standard thoracic endovascular aortic repair techniques. It's a little explanation here. Frozen stented elephant trunk techniques is a single piece combine a stent graft and a branch Dacron graft. Stent graft is deployed antegrade through the open arch during hypothermic circulatory arrest at the same operation, the index operation. And the stage repair, usually it's a zone 2 hybrid arch with stage endograft insertion. So the distal anastomosis is constructed at the level of the left subclavian artery. The osseum of the 3-arch branch is transposed to a more proximal location, so leaving a 2 to 4 centimeter length of Dacron as a landing zone for the endograft. And the stent graft is deployed retrograde from the femoral artery after separating from CPB or weeks later. So immediate extended distal repair using the frozen elephant trunk technique may induce a false lumen thrombosis and remodeling, thereby preventing leg downstream dilatation. It's a work of Professor Shrestha from Hanover. But it comes with an increased risk of stroke, a spinal cord injury. We can see here the spinal cord injury rate is about 5%. And above all, increased surgical complexity, which is especially important because, as you know, these patients typically require emergent surgery in non-ideal timing. Since not all patients survive to late follow-up or have a residual dissection downstream after hemi-arch repair, a frozen elephant trunk strategy is, in our opinion, for all patients, may put more patients at immediate risk than that may benefit on the longer term. We therefore consider the frozen elephant trunk technique is a more complex and costly procedure to be applied routinely to all of our acute key type A patients. In our institution, we advocate for the approach of a stage repair of TIVA. The approach consists of stage 1, which is a 2/3 arch replacement where the arch is resected at zone 2, proximal to the LSA, and stage 2 will be TIVA with LSA bypass weeks after the index surgery in the window of plasticity. Back to our patient. This is the homemade branch graft. We do it on the table. A 2/3 arch replacement was done under moderate hypothermic circulatory arrest, and distal anastomosis was done proximal to the LSA. And when coming off bypass, we explored the iliac vessels on the table and found now there was good flow from both sides of the iliacs. A CT scan 1 week later showed partially thrombosis of the false lumen. As you can see here, there's now flow to the visceral vessels and both iliacs. The true lumen was open, and this is the true lumen here. Open, we see the flow to the iliac. 2 weeks later, we did a TIVA uneventfully, and the patient was discharged at post-op day 21. Some more cases as our center performed with the same approach. So I'd like to conclude extended repair of distal arch in acute type A dissection include malperfusion, disease of the distal arch, and descending aorta. Frozen elephant trunk can promote thrombosis of the false lumen and prevent leg dilatation and redo, but there is a risk of spinal cord injury and paraplegia. A stage repair with TIVA techniques is a reliable approach to address acute type A dissection with malperfusion syndrome. Thank you so much for your attention.
So thank you. Thank you for your nice presentation. We have now the next presentation. I would like to invite Professor Nguyễn Tùng Sơn. Professor Nguyễn Tùng Sơn come from Vietnam. He worked now in cardiovascular and thoracic center of international relations departments. His specialty is cardiovascular interventionist. Besides, he also the member of the Vietnam Cardiovascular Surgery Association and a member of Vietnam Cardiovascular Association, and also a member of Aortic Association. So the presentation will be purposive of aortic intervention, please.
Hi, Chairman. I'm the person. I'm come from the Vietnam Hospital. This morning, I have to honor to be here to present my brief presentation about the advance of endovascular and hybrid treatment of aortic disease. And now I start my presentation. It's my hospital, Vietnam University Hospital is the only modern hospital in Vietnam, and focus on the surgical activity and the oldest center of cardiovascular and thoracic surgery in Vietnam. And thoracic aortic disease, this all the thoracic aortic aneurysm involve the thoracic abdominal aortic aneurysm and acute aortic symptom of aortic dissection, type A and type B, IMS, PAU, and PTAI, blood thoracic aortic injury. And this is a video to modify to the TIVA. very easy to, you can see that you can release the stent and stent grafts to cover the lesion. And this video. This is all from to the naturalist company. I modify here and release the stent, and the stent it says cover all the lesion. Okay, so I focus on TIVA for to take easy. The rule is the covering as external tear to thrombus of the foramen, open the true lumen, and remodeling of our time. And you have some technique TIVA for the article dissection in my center. If the penetration by the balloon come from the true lumen go to the foramen, and I use the balloon to create a new penetration to the some this patient we have ischemia of the limb, ischemia of the abdominal, ischemia of renal. Sometimes we use a graceful technique from to the double Y and create a new penetration. But sometimes create a penetration only is not enough, and I put a stent for the left renal or right renal, or sometimes the SMA. And you know that when you put TIVA the first choice, after that sometimes the foramen not the thrombosis. That's why I can use the some technique you can use. This is a candy block, this is a wrist blocker, and then balloon to the open this the true lumen here to the thrombosis of the foramen, and if you practical you use a stand, a metal stand with the big eye, and open the true lumen, and more blood applied for the renal artery and SMA. And this is a candy blood technique modified in my standard. You use to send for naturally. You will structuralize this and put divide and put on the divide onto the foramen, and you put the foramen. After that, I use block from ASCI to Taiwan and occlude the divide. And sometimes a TIVA for the blood thoracic aortic injury. You can see that is type B for the B-type, and I put a stent, I cover the LSA. Easy for only for the descending aorta. This is type B, type 3 of the B-type. And I put a stent, but I penetration for the LSA. You can see here. This patient over to cover the stent, and this patient here for cover the descending aorta. And sometimes you use the TIVA and chimney. You use some cover stent. You want one or two or three chimney. And sometimes I put a stent for the descending from the LSA to the descending aorta with a long periscope. And sometimes you want to new technique, you have the penetration or open a hole inside the stent and hold back table on table. And our structure by to the remarker. After that, you put the detail inside. You see that this is a hole, and the core not cover the LSA. And I put the stent for to the cover to LSA to reverse LNA, and not to bypass, not to the chimney. And modify is a history. You use a TIVA in hybrid. You have open cervical value and thoracic endovascular aortic repair, a various value of a super aortic extra anatomy bypass or ascending to the intermediate and left carotids, and ascending aorta replacement or ascending aorta to the warping to reimplant the TABC and left carotids, and right carotid to left carotid or left carotid to the left subclavicle artery bypass. And after that, it puts a stent like this. And this is some case I put a stent. You can use a bypass from to the left right carotid to left carotid, and to the transportation of the left subject get people study, and after that they put a stand like this, even big area like this. Okay, sometimes I turn to the total the branching, and after that I put a stand. And sometimes I use the hybrid style A, you know the fast modify. Only to the aortic replacement. After that, the total rebranching for the owner, the supra aortic vessel. And after that, when I open the hole from to the aorta, I put the stent. And after that, the cervical and scrotal by shoulder and advanced it is cheaper, and technique is not complex, quite safe, effective, and sometimes I can do it in the operation, not require the CM. And as a result, have a total replacement of the ascending aorta and the branching, and put the stent inside. And some had a vertical busy of the suprarenal and the thoracic abdominal and emergency aorta. I use the bypass. You will see that you have 3 and 4 plan a bypass from to the aorta, go to LMA, go to the cilia, go to the 2 both of renal, and after that they put the stent on covers this like this. This is my old patient, and 5 years later it's okay now. And some use a voltaic technique. You can see that you use a viable or cover stent may be flexible, and after that you solder to the form to aorta, go to these 2 cover stent. This is in my case from the disease treatment disease of the ascending aorta. Involve a little bit problem. That's why you can put divide all the same for TIVA, or can put all the same onto the heart. You open a little from to the heart, and I push the stent like this and cover this problem for ascending. I think in the future is more and more hope in the future for treatment of ascending aorta. And sometimes this case is a disease of ascending aorta is the first hybrid and total endovascular method in the human in the central in the Brazil. You use some device, you can use something, you can TAVI or replacement of aortic valve. After that, you put a stent graft, you make the fenestration and put the 2 scope stent from to ASCI. In the first case in human for total endovascular method. And some had some technique and some instrument you can use frozen technique first. You can use like this hybrid device and cover on the replacement and cover on the open the true lumen form to aortic arch. And sometimes it's total endovascular fall to aortic arch is some device. It's not available in Vietnam now, but I hope in the future. And some disease of the TA and supra you have to the some multi-brain, iliac brain or fenestration spread graft fall to the but now it's available in Vietnam, but it's the price is so impressive. That's why I don't to try now. And in some case, you can see that this patient is young patient is acute type B complicated main perfusion syndrome, which is by you can see that there are a last in-child tear like here, and I carotis bypass hybrid produce from the right carotis or left carotis, and I put a stent graft. After put a stent graft, you can see that I lost my left renal from the true lumen. That's why I want to create a new fenestration. I come to the This is a from true lumen go to the foam lumen, and after that I use a balloon, open the balloon to create a new penetration here to save the red granule, and after that I check Azure. You can see that now new penetration and some more supply for the left granule asteroid. This is a warping technique. You can see this is for some patient is too old. You can do total replacement of the granule ascending avatar and total debranching. And after that, I use the warping to reduce the diameter of the ascending avatar and total debranching. And after that, I put stem like this. You can see it's yeah, it's not a little and a little degree, sorry. And that's it my result. So I click. And follow up 1 year. You can see that's a picture. And thank you for the attention. It's my team. And it's my case. Yeah, hope now thank you for the attention and hope see you later in Vietnam after the COVID-19 academic pandemic is normal. Thank you.
Korea is the director of cardiovascular image of Heart Institute ASCI Medical Centers. His topic is 4D flow image of aorta. Is it promising? Dr. Yang, please.
Thank you, Chairman, for the kind introduction. Now, the question given in my presentation is that is it promising for the flow MRI for aorta imaging? My answer is yes. I think the flow MRI has a unique role in aortic imaging. The first is for the flow MRI could unveil complex flow pattern in the aorta and each branch. And second, for the flow MRI could provide hemodynamic parameters for the predictive aortic imaging. And finally, for the flow MRI could be helpful for explaining hemodynamic phenomenon, and ex vivo imaging could be helpful. Today, I would like to explain these following unique roles of for the flow MRI in my talk. Let me show you this case again. This patient underwent ventral operation and replacement of ascending aorta and total arch. There is plication deformity with mild luminal narrowing at the proximal anastomosis site and distal anastomosis site between aortic arch graft and descending thoracic aorta was performed using elephant trunk procedure. Therefore, aortic arch flow runs through this flap-like pre-graft end. Then, what flow patterns do we predict in this post-operative aorta morphology? For the flow MRI can provide flow pattern. You can see the flow acceleration at the proximal anastomosis site and through the elephant trunk graft. Also, there is some falling and helical pattern of aortic flow at just the distal portion of the anastomosis site. A more dramatic example can be found in this article by Dr. Sakada from Hamamatsu University in Japan. They very nicely showed for the flow MRI analysis of endoleaks after endovascular aneurysm repair. This is type 3 endoleak between aortic graft and left limb graft. For the flow MRI clearly demonstrate the endoleak flow from the stent graft gap here. This is type 4, diffuse leakage of contrast medium around aortic stent graft. For the flow MRI showed diffuse and multidirectional flow pattern around the stent graft, which is compatible with type 4 endoleak. Type 2 endoleak is related with aortic side branch, such as lumbar arteries or inferior mesenteric arteries. Discrimination between type 2A and type 2B is almost impossible in conventional imaging modalities such as CT angiography. By definition, type 2A shows to and fro flow pattern, and type 2B showed inflow and outflow connection type, as you can see this panel. Take a look at this fascinating case of type 2A. Now you can see the to and fro pattern of blood flow in the inferior mesenteric artery, which means type 2A endoleak. In this case of type 2B endoleak was occurred by lumbar artery branches. On 4D flow MRI, endoleak flow comes from the left lumbar artery branch and goes to the right branches. Another important role of 4D flow MRI is providing hemodynamic parameters might be useful predictive aortic imaging. This is the commonly used advanced analysis parameters, including Washoe stress, first wave velocity, and turbulent kinetic energy. Today, I would like to talk about turbulent kinetic energy. This is very well-known Bernoulli principle. Bernoulli principle is very basic rule when we use estimate pressure difference. Difference resulted from a stenosis using velocity-based method such as echocardiography. A very typical example is the aortic stenosis in clinical circumstance. For estimation of a pressure loss across the stenosis, a flow velocity measured in a vena contracta is frequently applied on echocardiography. But the limitation of this method is very well known as a pressure recovery phenomenon, particularly in more complex shape of stenosis such as prostatic valve failure. Measurement of turbulent kinetic energy could have a clinical implication because the dominant cause of irreversible pressure loss is the turbulent kinetic energy. Let's imagine two boxes containing similar phase and heterogeneous phase information here. As compared to the laminar flow, turbulent velocity distribution within the box shows a low signal intensity due to destructive phase interference. Peter Diverfeld in Sweden suggested the computation method of turbulent kinetic energy using MRI. He computed the standard deviation of the blood flow velocity distribution within a box, and he proved MRI is feasible method for TKE measurement using Doppler method as a reference standard. My team also performed in vitro validation of MR turbulent kinetic energy measurement. In addition, we applied TKE measurement in patients with aortic stenosis. Particle image velocimetry was the reference standard for validation of turbulent kinetic energy measurement using 4D flow MRI in my study. Using PIV, we can evaluate a very detailed flow phenomenon, as you can see this post-TAVR in vitro flow phantom. MRI measurements of TKE showed a very nice agreement with the reference standard PIV. This is a very early results of TKE in patients with aortic stenosis. Based on the results of echocardiography, all these 4 patients are severe stenosis, but turbulent kinetic energy in these 2 groups looked quite different. TKE was not consistent with the transvalvular pressure gradient by echocardiography. If TKE is more accurate indicator of a pressure drop, it means that echocardiography may misclassify some patient to severe aortic stenosis group. In the prostatic valve stenosis, velocity-based estimation of a pressure drop has clear limitations because the vena contracta did not form clearly as compared with the simple type of stenosis. In this phantom study, TKE showed a nice predictive value of pressure drop in the prostatic valve stenosis. The third law of 4D flow MRI is the explaining hemodynamic phenomenon. For this task, sometimes we need the help of ex vivo imaging, such as particle imaging velocimetry. I think the role of ex vivo imaging in 4D flow MRI is similar with pathological specimen in the conventional morphologic imaging. To understand hemodynamic phenomenon on 4D flow MRI better, we need to understand fundamental phenomenon of 4D flow MRI on ex vivo imaging. The first phenomenon is helical flow in the ascending aorta. This is a very famous article showing an association between elevated wall shear stress and weakened elastic fiber in the aortic wall, published Jack in 2015. They compared with the wall shear stress map here with pathology specimens in patients who underwent aortic valve surgery. This is another famous paper showing an association between helical flow patterns in the ascending aorta and bicuspid aortic valve morphology. The main finding of this study were flow abnormalities may be a major contributor to aortic dilatation in the bicuspid aortic valve, and fusion type of bicuspid valve affects the severity of flow abnormality. Let me introduce these 2 cases showing different aortic flow inflow angles. In upper panels with tricuspid aortic valve showed a central inflow angle, as you can see here, without aortic dilatation. In lower panel with bicuspid aortic valve showed on very eccentric flow angle, as shown here, with the dilated aorta. My question was that, is there any association between aortic inflow angle and helical flow pattern? So that was motivation of our phantom study. Then we did a phantom study using a 3D printed aortic model from real patient and 4D flow MRI. Here are the results. Posterior aortic flow results in right-handed rotation and more severe helical flow as compared with the anterior aortic flow. Right aortic flow results in right-handed rotation. And this panel summarizes the association between aortic flow angle and helical flow direction. This phantom study suggested that helical flow itself may be results of aortic inflow angle, not by valve morphology. The second topic is prostatic heart valve failure, subvalvular panels formation. This is the very first case that I experienced. A 60-years-old lady who underwent aortic valve replacement 17 years ago experienced cardiac arrest and recovered. On echocardiography, valve movement was normal, but pressure gradient was elevated significantly. On CT, there was a linear and membrane-like lesion at the subvalvular portion. At that time, my counterpart clinician, who is an experienced cardiologist, did not convince CT findings. So it was not easy to determine redo surgery, redo AVR. After a long time of discussion, redo surgery was performed and subvalvular pannus was removed and the transvalvular pressure gradient was dramatically decreased. After noticing pannus, I tried to retrospective analysis from CT data and tried to evaluate severity of pannus quantitatively. And I suggested encroachment ratio. The encroachment ratio showed nice correlation with transvalvular pressure gradient on echocardiography. There is a very interesting hemodynamic phenomenon related to the pannus formation. Take a look at this patient showing motion limitation on CT. Here, this leaflet is opened, but this leaflet did not open. There was a subvalvular pannus here, but in the surgical field, there was no motion limitation in the prosthetic valve. After experiencing this case, my question was that, is there any hemodynamic effect of subvalvular pannus causing restricted leaflet motion? To answer this question, I did an in vitro experiment using a 3D printed subvalvular pannus model. Here are results. As compared to normal, in a model with significant pannus, leaflet motion was significantly decreased. This motion restriction changes the flow pattern around the valve leaflet and causes aggravated the transvalvular pressure gradient. Probably when there is pannus formation, torque force to open the leaflet may reduce. I think this is a mechanism of pannus-induced leaflet motion restriction. In vitro 4D flow MRI also revealed this hemodynamic change of pannus formation as compared without pannus. Ascending aorta flow with pannus is dramatically changed eccentrically. The third topic is the thrombus formation within the sinus of Valsalva after TAVR. In 2019, my group reported thrombus formation within the sinus of Valsalva here after TAVR for the first time. In this case, you can see the thrombus formation in the native aortic leaflet after TAVR as compared to the preoperative CT. Of note, this is a newly developed thrombus after implementation of TAVR valve. This is an ongoing ex vivo experiment to elucidate the risk factors of sinus Valsalva thrombus formation. In the experiment, the degree of flow stasis was quite different according to the valve type, implementation location, and the native leaflet length. Still, we have a lot of hurdles for the clinical application of 4D flow MRI. A dedicated software module fits into a specific clinical scenario, such as pressure gradient estimation, could be a solution, and I hope my group could contribute to setting up this solution. Using 4D flow MRI, we can see the flow pattern, but we are not sure which flow pattern is the pathology that requires treatment. That is main problem we face after we apply body flow MRI in the clinical practice. To solve this problem, we need a reference standard for health volunteer, and we need develop a more prognostic marker, and we need more evidences in longitudinal follow-up studies. This is an ongoing volunteer study in my institution. We are gathering normal hemodynamic parameters using body flow MRI from volunteers who confirmed to normal using echocardiography as a reference standard. Ladies and gentlemen, this is my conclusion. Body flow MRI has excellent potential, but lots of limitations are still exist. So, further studies are needed to prove a clinical additive value of body flow MRI. Thank you very much for your kind attention.
Thank you. Thank you, Professor Dong Hoon Yang. You have a very interesting study concerning about the four flows imaging of the aorta. And right now we have 10 minutes for discussion. I see we have from the audience, we have a question to Professor Wu. That's it. I have a question about the protocol for evaluating thoracic aortic disease. Do you use ECG, rated CT? Yeah.
Okay. If my understanding is correct, the question is the evaluation of the CT of aorta using the EKG gating or not. This depends on what kind of scanner you used. For the critical issues, if in the previous age we in our emergency department room we have a 64-slice CT scanner only, and our experience is that for 10 cases of susceptible acute aortic syndrome, it actually is true positive is just about 2 or 1 or 2 cases. Many cases are not aortic dissection, acute aortic syndrome. So in that case, we did not use routinely EKG gated. We used the non-EKG gated first. And if this is the true cases, and to identify the type A inlet is very important, and we will repeat EKG gating scan later before the surgery. This is our previous protocol. But now if we have a state-of-the-art scanner, that actually is not much difference with gating or not gating to identify the inlet. For diagnosis of the acute aortic syndrome, which type, we don't need the EKG gating. But if you want to detail the inlet, 64 slices need EKG gate, but higher scanner such as dual source or white detectors, my experience is no EKG gate is okay. We can identify the inlet as well. This is my answer.
Another question, please.
What?
Trong WhatsApp của cậu không
Không có.
The meaning, I have answered the question. I am not sure what's the other case. other question? I have a question to the Professor Donghyun Yang. In your 40 flow protocol, what's the average scan time need to get the data?
Okay, thank you for asking. Can you hear me?
Yes.
Scan time highly depends on which body part or scan range. If we want to include all aortic arch or whole heart, scan time increase up to 30 minutes. I think 30 minutes scan time is not acceptable in clinical setting because default setting scan time 30 minutes mean real scan time also increase depends on patient heart rate or irregular heart rhythm. So default scan time 10 minutes is acceptable in clinical settings. So we need to change scan range as minimum to as possible. So in my routine clinical practice, average scan time of 40 flow MRI is 10 to 15 minutes.
So what's the minimal spatial resolution is required to your opinion to get a good flow presentation?
Yes, that is also a very important question. As you know, spatial resolution is dependent on spatial resolution is also highly related to the scan time. So if we want to get small size spatial resolution, such as 1 millimeter isovoxel, scan time will be increased. But in the SCMR guideline, minimum requirement of spatial resolution is 3 millimeter isovoxel. As you know, 3 millimeter is not so accurate spatial resolution. If we use 3 millimeter spatial resolution, scan time is not so long. We can scan almost case within 10 minutes. But in my clinical practice, I reduce spatial resolution to 2 millimeter or 2.5 millimeter isovoxel. Isovoxel is very important. Isovoxel is very important for post processing. Okay, thank you.
Thank you.
Okay, thank you. I have a question for Professor Wu. I'm very impressed about the Chinese ring square sign.
Yes.
Yeah. And we see someone aortic disease. It's big in acute aortic syndrome. If they have a Chinese ring square sign, they have a very bad prognosis. So between the patient who haven't the Chinese ring square, is there the difference of the intervention? For example, the surgery or endovascular intervention? Well, how about the decision in that case?
Yes, it is so actually Chinese ring square sign is multiple intramural blood pool, right? And so if we also have a study on about the number of the multiple intramural blood pool on the impact. So actually, number is more than 4 is not good to our experience. So less than 3, the intramural blood pool is usually okay. But more than 4, you should pay more attention and consider whether it will communicate each other to become a forced woman. That's what I think. And become forced woman depends on the patient. If there is a type B, that is okay. Intramural blood flow usually at type B, not type A, because there's no branch in the ascending aorta, type B. So type B forced woman is, in fact, it's also okay, but just need to pay more attention on it. Yeah.
And how about prevalence, especially in your experience? It is no?
So much, so many. Intramural blood flow is very rare. Just 2 or 3 cases in my 10, 20 years. Yes.
And how about your ID, Professor Ding? You have a comment about this?
I just have a
application.
I have one question from Mr. Wu. Yeah. So how often, how frequently do you do CT scan on following patients with acute IMH type A or retrograde type A? And what are the signs of, alarm, can raise alarm for surgeons?
Oh yeah, this is a very practical and difficult questions. In our condition that we will follow up in acute phase. If there is no sudden progress of the symptom, we will follow up first week, then 2 weeks, and then the patient transfer from the ICU to the ordinary ward. After that, before the condition is stable, then after when he was discharged, we'll follow up again. Then 3 months later after the discharge. But in any time the condition gets worse, it is an indication to do the CT scan. So when to alarm to the surgeon is that if the initially there are some guidelines about the IMH. If the outer diameter more than 5 cm or the IMH more than 1 or 1.5 cm, or any complications such as axillary projection or penetration or hemopericardium, that should be initially should go to the surgeon. And if not, then we can observe with intense medical treatment in our hospital. Especially if the patient is an elderly patient, we will use the intense medical treatment to control the blood pressure and the pain relief. Yes, that is our current strategy.
Sometimes it's difficult. For example, I'm having a patient, a Chinese man coming to our hospital, and then something is just in the limitation. For example, the thickness of IMH at the ascending aorta now is at 14. And there is a pericardium, hemopericardium at just 5 millimeters, and a small finger-like projection at the arch. So in this time of COVID-19, it's not easy to make a decision. Now the patient is in the ICU, and I'm reluctant to do surgery or follow up the patient. So I am deciding to do a CT scan every 2 or 3 days to see the evolution.
Okay. No, we did not follow up so frequently every 2 or 3 days. Well, about 1 week, if the condition is okay. Yeah.
Yeah. Thank you.
Okay, well, thank you. Concerning about the presentation of Professor Dong-Hoon Yang, Professor Yang, it's very, you have a question, is this promising? I think it is, yes it is. but in case of valve replacement. You use the 4D flow imaging to evaluate, but I didn't see the comparison with other techniques. For example, 4D ultrasound, echocardiography, speaker tracking. Which is the better? How about your opinion? Thank you.
Thank you for your question. That is quite a difficult question. I think that 4D flow is not, purpose of 4D flow is not a replacement of conventional modalities such as echocardiography or 2D phase contrast MRI. If we want to simply measure flow velocity or amount of flow, 2D phase contrast MRI is enough. If we want to use 4D flow MRI, we need to find very unique scenario. 4D flow MRI is helpful, as I demonstrate you. Unique point of 4D flow MRI is calculating some complex parameters for more predictive image or demonstration of complex flow pattern, which is not available conventional 2D echocardiography or 3D echocardiography that I showed you. So we need find the value of 4D flow MRI. I mean a replacement of conventional imaging is not purpose of 4D flow MRI. Thank you. But there is very many works we should do for use 4D flow MRI in my clinical practice. So we need more research. Yeah, that is my answer. Thank you.
Professor Min, you are mute. Professor Min, you are mute.
Yeah, you can sign. And now we can have a short summarize about excellent presentation. This the end of the section. We have 4 presentations. The first one is concerning about the presentation of Professor Wu. We have a new classification of aortic disease following the 2020 of SVS and SCS. Is very interesting when you compare with 3 cases, clinical case. And the second one, that's the pathogenesis between the triangle AMH, the Fons at the answer, and Fons lumen. This is still debated, but it's very interesting, I think. And then impression also the Chinese ring square sign. It's a sign alarm to show the bad prognosis. And the second presentation concerning about Professor Myung Han, new trends in surgical decision making and technique, where he has many experience in this field by applying the 2 techniques by comparison 2 techniques at the same time. The first one at the conventional, the elephant technique, trunk technique, and the second one that's the stage and extend repair. It's combined with TIVA. I think this is very unique and it is suitable, especially in Asian patients. The third presentation, this is the Nguyễn Tung Sơn, Dr. Nguyễn Tung Sơn, this is the advance of endovascular and hybrid trends in aortic disease. And the last one, that's the 4-flow imaging. We discussed many things about the 4-flow imaging, and I think this is very promising in the future. One is on behalf of the chairperson and the committee, I would like to thank you so much for your contribution, especially the information confirm your very update presentation. Once again, thank you so much, and see you again for the next congress of our congress. Thank you, and goodbye. Have a good lunch.
Thank you.
Have a good lunch.
Thank you.
To the dreamers who imagine the impossible, who inspire the world with their ideas, and strive to provide clear answers for early and accurate diagnosis, for better outcomes, for better health, for every patient. Bayer wants to join you and make this dream come true.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.